If a majority want, we can start now itself, because I always believe that those who logged in on time should not be kept waiting. So we'll start, and those who want, let them join in between, and they can also anytime join and exit according to their convenience. Okay. Dr. Anuja, are you free? Are you ready?
Yes, sir.
Okay, please start. Please start.
Okay, sir.
Anuja, you can start.
Yes, sir. Ma'am, screen sharing. You
can do that.
Ma'am, screen sharing disabled ആക്കിയത് മാറ്റാവോ?
ഞാനത് ഡിസേബിൾ ചെയ്തിട്ടില്ല. മേ ബി അബിയോടൊന്ന് ചോദിച്ചു നോക്കട്ടെ. ഡിസേബിൾഡ് കാണിക്കുവാണോ?
അതെ മാഡം.
ഹലോ അബി, അത് സ്ക്രീൻ ഷെയറിംഗ് ഇങ്ങനെ ഡിസേബിൾഡ് എന്ന് കാണിക്കാന്ന്. അപ്പൊ അനുജിക്ക് സ്ക്രീൻ ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല. ഹലോ ഹലോ എന്തോ? അല്ല, അതല്ല അബി, എനിക്ക് എന്റെ ലാപ്ടോപ്പ് അല്ല, എന്റെ ടാബ്ലറ്റ്. ടാബ്ലറ്റിൽ നിന്ന് എനിക്ക് ഇതൊന്നും ചെയ്യാൻ പറ്റുന്നില്ല. അല്ല, അനുജ് തന്നെയാണ് സ്ക്രീൻ ഷെയർ ചെയ്തത്. അനുജ് പറയുന്നത് ഡിസേബിൾഡ് ആയിട്ട് കിടക്കുവാന്നാ പറയണത്. ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല. ശരി. ഇപ്പൊ ശരിയാക്കാം അനുജ.
ഓക്കെ മാഡം.
Anuja, വേണമെങ്കിൽ you can start just ആദ്യത്തെ 2-3 സ്ലൈഡിലൊന്നും നമുക്ക് സ്ലൈഡ് ഇല്ലെങ്കിലും start വേണമെങ്കിൽ. It's up to you, Anuja. It's whatever.
Okay sir, that we can do.
And then അത് enable ആവുമ്പോൾ ഒന്ന് enable ചെയ്തോളൂ, and then inform.
Okay. Good evening all. I am going to present case of Mr. Ravindran Nair, 62-year-old male. He is from Trivandrum, examined on January 2023. Presenting complaints of diminution of vision in right eye since 1 week. History of presenting illness. Patient was apparently normal 1 week back. Then he noticed sudden diminution of vision in right eye after waking up from sleep. It was up to such an extent that he was unable to identify faces. No history of transient obscuration of vision. No history of
Right.
model. And model.
History of presenting illness. Patient was apparently normal 1 week back. Then he noticed sudden diminution of vision in right eye after waking up from sleep. It was up to such an extent that he was unable to identify faces. No history of transient obscuration of vision. No history of any trauma to eye. No history of flashes of light or floaters. No history of headache, nausea, vomiting or colored halos. No history of pain, redness. Ma'am, audible ano, madam?
Yes, you are audible.
Coming to past ocular history, patient has been using glasses for the past 20 years. Last change of glasses was 1 year back. No history of lasers, injections or surgeries in the past. Past medical history, known case of type 2 diabetes mellitus for the past 20 years on oral hypoglycemic drugs and insulin, inadequate control. Known case of hypertension since 10 years on treatment. Known case of dyslipidemia since 10 years on treatment. Known case of chronic kidney disease for the past 1 year on treatment. No history of cerebrovascular accident or ischemic heart disease. Coming to personal history, mixed diet, no addiction to alcohol or smoking, no history of any drug allergy. Coming to general examination, he is moderately built and nourished, conscious, oriented to time, place and person, bilateral pitting, pedal edema noted, no pallor, no icterus, no clubbing, no cyanosis, no generalized lymph node enlargement, no skin rashes or nodules. Coming to vitals, pulse rate was 82 per minute, regular in rhythm, normal in volume. Carotid pulsations felt equally bilaterally. Blood pressure was 180 mm mercury. Respiratory rate was 12 per minute, afebrile. Coming to systemic examination, central nervous system, higher mental function normal. Cranial nerve examination, olfactory nerve, perception of smell normal. Second, third, fourth, sixth cranial nerve will be discussed later. Trigeminal, facial and corneal sensation normal. Muscles of mastication normal. Facial nerve, no deviation of angle of mouth, normal wrinkling over forehead. Vestibulocochlear nerve, no hearing impairment. Coming to ocular examination, orthophoric in primary gaze, no facial asymmetry, no ptosis, proptosis, nystagmus or strabismus, no head tilt, face turn or chin elevation. Ductions, versions and vergence are normal. Coming to visual acuity, uncorrected visual acuity was in right eye counting finger 3 meter N36, left eye 618 N8. Best corrected visual acuity in right eye there was no improvement. In left eye 612 N6. Retinoscopy done at a working distance of 2/3 meter. Dull glow noted in right eye. And left eye there was plus 1.5 in horizontal meridian and plus 3 diopter in vertical meridian. Near art was plus 3 diopter. Coming to anterior segment examination of right eye, lids and adnexa normal, conjunctiva normal, episclera and sclera normal, cornea normal in size, shape and luster, anterior chamber Van Herrick's grade 4 coed, iris normal in color, no neovascularization of iris noted, pupil 3 mm, direct and concentric light reflex sluggish, no RAPD noted, lens nuclear sclerosis grade 2 noted, anterior vitreous phase showed RBCs. Intraocular pressure measured with Goldman applanation tonometer and was 16 mm of mercury. Coming to anterior segment examination of left eye, lids and adnexa normal, conjunctiva normal, episclera and sclera normal, cornea normal in size, shape and luster, anterior chamber Van Herrick's grade 4 coed, iris normal in color, no neovascularization of iris noted, pupil 3 mm, direct and concentric light reflex sluggish, no RAPD noted. Lens nuclear sclerosis grade 2. Intraocular pressure was 16 mm of mercury. Coming to fundus examination of right eye with distant direct ophthalmoscopy, absent fundal glow noted in right eye. In direct ophthalmoscopy, media was hazy in right eye. Examination of posterior pole with 90 AD lens, media was hazy. With indirect ophthalmoscopy, media was hazy due to vitreous hemorrhage and lens opacity. Disc and macula not clearly visualized. Dark red preretinal hemorrhage noted temporal to macula. Large patch of preretinal hemorrhages noted inferior mid-periphery. Visualized peripheral retina seems to be attached. This is the fundus picture of right eye. Coming to fundus examination of left eye. Distant direct ophthalmoscopy showed good fundal glow in left eye. Direct ophthalmoscopy media was clear. Examination of posterior pole with 90D lens, vertically oval disc. Cup-disc ratio was 0.3, well-defined margin, healthy neuroretinal rim, origin of vessels normal. Arteriovenous ratio was 2:3. Coming to fundus examination of left eye with indirect ophthalmoscopy, media was clear. This vertically oval, distinct disc margins, cup-disc ratio was 0.3, neuroretinal rim pink, peripapillary area appears to be normal, origin of vessels normal with AV ratio of 2:4, multiple dot and blot hemorrhages noted in all 4 quadrants, multiple areas of fine arborizing vessels less than half disc diameter noted, superior to supratemporal arcade, 2 disc diameter away from the arcade. Yellowish waxy intraretinal deposit with distinct margins seen inferiorly perifoveally suggestive of hard exudate. Veins are dilated and mild tortuous with AV ratio of 2:4. Macula, foveal reflex was absent. A thick white shiny membrane which is transparent seen in the macular region of size 3 disc diameter. This is the fundus picture of left eye. Summary, 62-year-old non-uncontrolled diabetic, hypertensive, dyslipidemic and chronic kidney disease patient presented to our OPD on January 10th with complaints of sudden painless diminution of vision in right eye for the past 1 week. On examination, best corrected visual acuity was counting finger 3 meter in right eye and 6/12 in left eye. Posterior segment examination showed hazy media due to vitreous hemorrhage and lens opacity in right eye. Pre-retinal hemorrhage noted temporarily away from the macula, and a large patch of pre-retinal hemorrhage noted inferior mid-periphery. Left eye showed multiple NVE superior to supratemporal arcade, 2 disc diameter away, dot and blot hemorrhages, hard exudates in the posterior pole, and macula showed ERM. Diagnosis, right eye high-risk PDR with vitreous hemorrhage, left eye early proliferative diabetic retinopathy, both eye nuclear sclerosis grade 2. This is the OCT picture of right eye. And this is the OCT picture of left eye.
Okay, Anuja. Anuja, you have made a good presentation. And the corrections and modifications which I mentioned are just to help you to improve later when you present in your university exam. Okay, it is not find fault. And only by presenting and correcting small mistakes, slowly will you be able to do better in your future presentation. Okay, in your university. And all university exams, we examiners are mainly involved in just finding out whether the postgraduate student has the basic knowledge to manage most of the conditions in a reasonable manner. We are not very concerned about the fine details about each and every condition, but a student is supposed to know the basic of each disease and answer the basic simple questions to pass an exam. And so my class also will be mainly the basics, and then depending on the time, and if you want, we can go to the advanced details stage. Okay, now first we'll start with the presentation. See, I'll just go to the slides which you have shown, okay, so that we can make some corrections in the because in your university exam you're going to give you're a DNP student or a PUHA student, one of them. I think you're a DAP student, no?
Yes, yes, sir.
So you will be asked to write all these things in an answer paper and submit it. And that is the only evidence of how you really performed in the exam. Okay, what you told in the exam and all may not be recorded. So your answer paper should be complete. Okay. And so each slide I may be just going one by one just to help you to understand what are the points which you can add or modify in what you document. Okay. So we'll start slide where you mentioned the patient details. You have mentioned the name, age, male honor, female honor, residence. Good. And when you examine, the occupation is also important. Okay. Occupation, all your patients, especially the cases where the vision is affected, it is important that you mention the occupation because your treatment and later prognosis, etc. The occupation is very important because he or she needs the vision for his daily activities and occupation. A college professor's requirements is different from a manual laborer, which is different from a old elderly housewife. Okay, so documentation is something which you should always document. You ask and you do it. Okay, and later, depending on the final vision, you may have to give rehabilitation also. You start with the medical treatment, then surgical treatment, and when both of them fail, or the patient's vision comes down drastically and none of them are going to help him improve, you have to go for rehabilitation also. So, or a rehabilitation will be tailored to his occupation and daily needs. So you can always mention the occupation of the patient. Okay. Then presenting committee I mentioned diminution of vision right eye for 1 week. Okay, okay. So that helps us to know that it's a sudden onset defective vision. Okay. And then history of presenting complaint, I mentioned it is apparently normal. He got sudden defective vision, right eye on waking up from sleep. This is what you have mentioned. Okay, fine. Diagnosis. Now we are also talking based on the diagnosis which you have mentioned. Okay, you have told me that he has got a vitreous hemorrhage. He has got proliferative diabetic retinopathy also. Why do you think he has got a sudden defective vision in, while getting up from sleep? What was the cause? When you look back, what do you think is the cause for his sudden decrease of vision when he gets up?
As he's a chronic hypertensive, and there can be a variation in blood pressure, and due to elevated blood pressure, there can be rupture of blood vessels and bleeding. Okay.
That's one reason. See, he is hypertensive, though the value we got is normal. When you examine his BP is normal, but then usually the BP goes up during the day, and in the night it is, no, evening and night it is high. And then in the morning it becomes normal, okay, or comes down. That's one reason, possible reason. There may have been, and then he has also got diabetic retinopathy changes. So there are friable new blood vessels due to an increase in the blood pressure may have ruptured in the night and has led to a vitreous hemorrhage. But irrespective of it, there is even the diabetic retinopathy which he has got new blood vessels as per your.
Not clear.
Not clear. Can I repeat? Can I repeat?
Sir, it's not clear.
It's not clear right now. Hello.
Clear answer.
It's now clear. Now
It's clear. Okay, I have got it close. Okay, I'll just
now clear.
One possibility is the blood pressure may have gone up in the evening or the night, and then the friable blood vessels which are there in diabetic retinopathy got ruptured, and it has led to the vitreous hemorrhage. Another possibility is the blood pressure was remaining normal, but the new blood vessels have ruptured. And when the patient sleeps, what happens? The blood sediments down, or by gravity goes and settles down in the posterior pole, namely the macula. And so that is why many patients, when they get up in the morning, they may notice, if there's a vitreous hemorrhage, they may notice a sudden decrease in vision because the blood is mainly in the macula. It has settled down in the macular region or the posterior pole when he is lying down.
Sir, and network problem.
Network problem undo. Clear alla.
Vittu pova.
No.
Yeah.
Understood.
Network problem maybe.
No, okay, no got it.
Now it's clear. Like in between, it's like the dialogues are cut.
Ipo kekamo? So we'll try it. So there are two possibilities. One, the friable new blood vessels in diabetic retinopathy ruptured, or the blood pressure went up and it ruptured the blood vessels, and the blood has accumulated in the posterior pole when the patient lied down. Okay, and so the blood is over the macular region when he was lying down, and so when he got up, he was not able to see well. Okay, so that may be what a possibility, especially when we look back. And then you see, you have asked. Why did you ask for any transient obscuration of vision?
To rule out whether there is any any central retinal artery occlusion, And
Okay,
to,
Doctor, that's all right. See, central retinal artery occlusion doesn't cause transient obscurations of vision, okay? But emboli, okay? Emboli, vascular spasms, okay? Amaurosis fugae condition. You can get transient obscuration. So in some patients, or any block in the peripheral part of the retina may cause a transient obscuration, especially spasms, emboli, etc. Okay, and so vascular causes of any retinal vascular causes can cause transient obscuration. Then you ask for history of trauma. That is because the vitreous hemorrhage can occur due to trauma. Yes. Then you have asked for flashes, floaters. When did you ask for floaters, etc.?
To rule out retinal detachment,
Okay.
and to rule out migraine aura.
Okay.
And to rule out floaters, to rule out any vitreous degeneration, and to rule out posterior vitreous detachment, and to rule out any vitreous degeneration. And
okay. When this posterior vitreous detachment, you may get some flash pull on the retina, and that will cause flashes of light. You can get floaters in early vitreous hemorrhage. You may get small vitreous hemorrhages or blood in the vitreous cavity, which can present as floaters. You may, so that's why some people may not have a sudden decrease in vision. They may present with flashes and floaters, and then later will come with a sudden decrease in vision. Now, headache, nausea, vomiting, colored halos. Why did you ask that history?
To rule out raised intracranial hypertension, and to rule out papilledema, and to rule out neovascular glaucoma.
Okay. Correct. That's it. That's also one condition which can occur in this patient. Okay. So to rule out any increase in intraocular pressure or intracranial pressure. Okay. That's the reason. And then you have asked for pain, redness, etc., which is seen sometimes when the intraocular pressure is raised.
Network issue unnallo.
Follow on down, doctor. Ipollo clear alle?
Clear answer. Audible answer.
Elizabeth clear alle?
Is it clear for everyone? I feel a network issue in between.
And ബാക്കി എല്ലാവർക്കും no?
Anuja, is it clear for you?
Yes, ma'am. എനിക്ക് audible ആണ് ma'am. കേൾക്കുന്നുണ്ട്.
Okay.
If others cannot hear, please just put a note. Means you can read our chat box. Then if majority are not able to hear, then I'll have to try another mobile. But let us.
It's okay. We can hear you clearly.
Okay. So we'll continue. Now we are going to the next slide. Past medical history. You have mentioned about the history of diabetes. Yes, that's important. History of hypertension, history of dyslipidemia, history of chronic kidney disease. Okay. And then you have asked for history of CVA and ischemic heart disease. That's also important because if the patient has got a history of coronary artery disease, he may be on antiplatelet drugs, and that also can cause this vitreous hemorrhage. Patients who are on CVA, there is a chance of, CVA is occurred due to either vascular occlusion or due to hemorrhages. And so these patients also can develop vitreous hemorrhage. And so that is why you have asked for the history in all these histories in the past medical history. General examination is all right. Vitals also all right. And please remember all these patients, all such patients, remember to palpate the carotids. You feel one side carotids, then you feel the other side carotids. Don't palpate both simultaneously, but make it a habit to palpate the carotids in all cases where you find some amount of ischemia or block in the retinal circulation. Okay. Then systemic examination, you have mentioned CNS examination. Just remember that you have written CNS musculoskeletal. For the sake of completion, always you just say systemic examination, CNS, CVS, GIT, musculoskeletal, and respiratory system. Okay, that you just mention all the systems, at least the names, when you present in the exam. Now, visual acuity, you have written uncorrected visual acuity and best corrected visual acuity. And right eye uncorrected is CF 3 meters, And then you have written best corrected not improving. Please mention not improving with pinhole. Okay. You must mention what you are trying to do to improve the vision. Okay. So right eye, best corrected visual acuity, the complete statement should be not improving with pinhole, not improving with glasses. Okay.
Oh,
And left eye, you have it's improving from 6/18 to 6/12. Okay. A retinoscopy you have done, the values also you have written. Okay, fine. Now, anterior segment examination of the right eye, you have mentioned all these things that I heard. And then iris, you have read, it's right. You have in all such cases, please realize when you see neovascularization of retina, always make it a point to look and document whether there is any neovascularization of the iris, especially the pupillary margin. Look closely at the pupillary margin. Angle of the anterior chamber in PGs are also supposed to, if we have doubts, do a gonioscopy and look at angles. So anyway, here you have written neovascularization of the iris, okay, and at least the pupillary area should be closely examined. Intraocular pressure you have recorded, good. Now coming to the left eye, also the same thing that has been mentioned. Fundus examination, see, usually what we do is one eye, we completely write all the findings, then we mention about the other eye. Okay. So here in your presentation, you have written anterior segment examination right eye, anterior segment examination of left eye, then you went to fundus. It will be complete eye and then go to the other eye. Okay. So now coming to the fundus right eye, you have mentioned distant direct ophthalmoscopy, absent fundus glow, then direct ophthalmoscopy, media hazy, then 90D examination and indirect. Okay, fine. And you have written there's a pre-retinal hemorrhage, etc. Okay, fine. And the diagram is there. You have drawn the diagram. The vitreous hemorrhage has been marked with green. The hemorrhage has been marked with red, and you can see the boat-shaped or D-shaped where pre-retinal hemorrhage, etc. Okay. Coming to the examination of left eye, you have mentioned the AV ratio is 2:3. Is that normal or abnormal? What is your view?
AV ratio 2:3 is normal.
Normal. Very correct. It is normal. Okay. Now let's go to the other eye. Fundus examination of left eye with indirect. You have mentioned that left eye. You have mentioned that the AV ratio is 2:4. That is normal or abnormal?
Abnormal. Abnormal, sir.
That means the veins are slightly distended or dilated. Okay.
Dilated.
You have mentioned multiple dot and dot hemorrhages, all that you have mentioned. You have mentioned that about the new blood vessels which are seen in the retina, and you mentioned about the hard exudates in the posterior pole. You have mentioned about a thick, white, shiny membrane seen in the macular area, 3 disc diameters in the macular area. Diagram Doctor, you have drawn a diagram and submitted it. The ERM's diagram, you have mentioned in your notes that is 3 disc diameters. Size.
Yes, sir.
Do you think that is the same diagram till your ERM diagram is the same size as 1 disc? Doctor,
Yes,
remember your findings should be what you draw. It should be proportionate to what you have described. Okay. Upon your ERM, you have written 3 disc diameters angle. The disc in the diameter. ERM the diameter should be 3 times what the diameter, the size of the disc which you have drawn. Okay.
Okay, sir.
Then we LM Kanichitonda. Okay, fine. So now your summary is there, and then diagnosis. See, doctor, you have mentioned diagnosis high risk PDR with vitreous hemorrhage. Correct. Correct, Anna. Left eye, you have written early PDR. That's also right. But then there are additional findings which you have mentioned. You have mentioned about the hard exudates in the macula. So there is PDR on the plus maculopathy on the plus ERM on the. These are 2, 3 which that also should be mentioned in the diagnosis. So early PDR with maculopathy or hard maculopathy and ERM. Okay. Now both eyes nuclear sclerosis grade 2. And then by convention, we also write the systemic diseases which the patient has in the diagnosis. See, your diagnosis, you have only mentioned the ocular diagnosis. But this patient has got diabetes, hypertension, chronic kidney disease, dyslipidemia, okay, as then only the diagnosis is complete. And then ECG finding you have shown, okay, we'll come to one by one. Okay, so doctor, this patient come to you for treatment. Any differential diagnosis?
Right eye differential diagnosis can be central retinal vein occlusion.
Okay.
And hypertensive retinopathy.
Okay.
And ocular ischemic syndrome.
Okay.
And
see, doctor, see, in this case, see, when you look at both eyes and with all the history and all, it is most likely PDR itself. But in the exam, if they ask what are the differential diagnosis, for the sake of discussion, you can always mention the following. You started off with the first thing you mentioned is the central retinal vein occlusion. Doctor?
Yes, sir.
That usually, central retinal vein occlusion usually doesn't present with pre-retinal hemorrhages. What you get retinal hemorrhages in all four cases. You get markedly distended retinal veins with retinal hemorrhages is tomato sauce. It's always spread throughout the retina. Okay, in all four quadrants. So central retinal vein occlusion may not be mentioned as your first thing. Okay, in the exam. You can always mention it if later, if your examiner keeps on asking for more differential diagnosis. But the picture which you have got in the right eye is not usually seen in, that is, you have got a vitreous hemorrhage, the view is not very clear, but you have got two pre-retinal hemorrhages. Such a picture is not usually seen in central retinal vein occlusion, a plain central retinal vein occlusion, okay? Unless the hemorrhages then come into the vitreous cavity, which is unlikely. But in the second one, you can mention hypertensive retinopathy. That's a possibility. It's a possibility where you may get blood vessels rupturing and you can get a vitreous hemorrhage, and such a picture may come in hypertensive retinopathy. The points against it is that you do not see any classical changes of hypertensive retinopathy in the other eye. AV crossing changes, you don't see it out there. Plus the BP which you recorded is also normal.
Nice.
So that we can mention, but it is not likely in this case. Then you mentioned ocular ischemic syndrome. Okay, that is a possibility, but here the carotids were equally palpated in both sides. And usually ocular ischemic syndrome need not cause a sudden painless defective vision. It may not very common. Okay. But other causes which can be mentioned. There's something called Paathsaala retinopathy. Paathsaala retinopathy. So you have to keep it. See, the main thing which you see in this case is a pre-retinal hemorrhage. Okay, and there are vitreous hemorrhages otherwise also. So Paathsaala retinopathy is one possibility. But then here the point against it is the patient doesn't give any history of straining, coughing, etc., or weightlifting, etc. Then there's another thing called Thurston syndrome. What is Thurston syndrome?
Intraocular hemorrhage associated with subarachnoid hemorrhage.
Correct.
And
you get pre-retinal hemorrhages along with any condition where the intracranial pressure increases, for example, subarachnoid hemorrhages. That's also a possibility. Though I'm just telling all these things just for the sake of a discussion. Okay. Then there's another condition called sickle cell disease. Okay. That also sickle cell retinopathy also can present with such conditions. Okay. Another condition is a retinal macroaneurysm. Okay. Some people have got retinal macroaneurysms which to cause a vitreous hemorrhage and pre-retinal hemorrhages. Okay. These are some of the possibilities which are there only in the right eye. Okay. But in the left eye, none of these possibilities are there. It is a very straightforward case of early PDR with maculopathy and ERF. Okay. So that's just for the sake of differential diagnosis. The next question the examiner will ask is, how do you plan to manage this case?
In right eye, as there is vitreous hemorrhage, and we can observe the patient whether vitreous hemorrhage is resolving or not, and frequent follow-up should be done. In the follow-up visit, if vitreous hemorrhage is resolving, we can start PRP in the seeing areas. And if the vitreous hemorrhage is not resolving in the follow-up visits, we can give anti-VEGF injection. And after vitreous hemorrhage resolves, we can do PRP in the right eye. And in left eye, as there is neovascularization NVE, and it is a case of early PDR, so we can directly start pan-retinal photocoagulation in left eye.
Okay. See, doctor, when an examiner asks you, how do you plan to manage the case? Any management is to be described under two headings. One, investigations, and two, treatment. Okay. So the first thing is investigations. The only investigation you have mentioned here, or at least the main investigation is the OCT. But baki kora investigations namal cheyendidana. So we go in an order. So let's start with management. Let's start with investigations. What all investigations do you plan to do for this patient?
Fasting blood pressure, fasting blood sugar level should be checked.
Yes.
Postprandial blood sugar should be checked, and HbA1c should be checked.
Very
And serum lipid profile, BP should be checked. Renal RFT, renal function test should be checked, and
Yes.
hemoglobin level should be checked.
See, any investigation you mentioned should have some importance in this case. See, hemoglobin is important because anemia has been well documented to increase the severity of retinopathy. Okay, so an anemic patient has got will progress faster in diabetic retinopathy. That has been documented. And so if the patient is anemic, we have to correct the anemia. Okay. You mentioned about blood sugar values, because one of the main treats, see, all this is based on different trials. Okay. And so blood sugar is an important parameter of in deciding the prognosis in this condition. So blood sugar has to be checked. BP control is also an important parameter. We'll come to the trials later, but that is why you mentioned the BP. Renal functions. Patients with deranged renal parameters, the retinopathy progresses faster. And so these are some other things which you have to investigate and rule out. Okay. Next, where any blood investigations cheyan ponundo? Any more blood investigations?
Platelet count.
Platelet count should be checked. Anything else? You can do a peripheral smear to rule out what's called blood dyscrasias. Okay, unlikely, but still, when you see hemorrhage in any part of the body, okay, and you can always just do a peripheral smear, or the total count, differential count can be also checked to rule out any leukemias, etc. Okay, which may be also a rare cause of, in this case, it is unlikely, but it's, you can do a peripheral smear to rule out any leukemia, blood dyscrasias, and also you may be able to see the sickling in some conditions. Okay.
Okay.
Next, blood investigations കഴിഞ്ഞു. പിന്നെ വേറെ എന്തെങ്കിലും investigations ചെയ്യാൻ ഉദ്ദേശിക്കുന്നുണ്ടോ?
Then B scan should be done.
Yes. B scan should be done in this case for what?
To rule out any tractional involvement, to rule out tractional RD.
Correct.
As there is no view in fundus.
Correct. Because you see, in this case, even with indirect, you are not able to see very well the condition of the retina. So you have to do a B scan in this case to see whether there is any retinal tear. You may not be able to see, but at least you can see whether there's any retinal detachment, any fraction on the retina, and that will definitely influence your surgery, whether you are doing medical treatment or surgical treatment. And also you can assess the amount of vitreous hemorrhage that the patient has at the time of you first seeing. Later, you also said that you are planning to observe and follow up the patient. So when you follow up the patient, you have to have an idea whether the vitreous hemorrhage is subsiding or not. Okay. So definitely you have to do a B scan examination of the patient's right eye to assess whether assess the vitreous condition and also the retina. Okay. And you can also see whether there is any PVD, vitreous detachment. Okay, because To do a vitrectomy, it will be easier if the vitreous has become detached. Okay. So that's why you do a B scan. Where ending investigation cheyan uddeshikkunundo?
OCT macula should be done in.
It should be done. E case you have shown the picture.
Yes.
Right eye, left eye.
In right eye, OCT macula was normal. In left eye,
normal, right? Left eye,
left eye, there is a hyperreflective membrane inner to the internal limiting membrane, suggestive of epiretinal membrane, and
Yes.
there is retinal thickening noted, and foveal contour is flattened, and there is small cystic spaces in the temporally, and there is hyperreflective spot suggestive of hard exudate temporally.
Yes. So definitely you can see the changes which are there in the macula of the left eye. As you said, there you can see the epiretinal membrane very clearly. You can see that the foveal contour has been changed. The normal depression in the fovea is obliterated. The retina has become thick. You can see hyperreflective areas which suggestive of the hard exudates. You can see cystic spaces in the macula. So definitely there is some amount of maculopathy for this patient. Okay. So OCT has been done for studying the macular region in both eyes, and that is routinely done in all such cases. Okay. Where ending investigation cheyan uddeshikkunundo ee patient?
In this patient, as this patient is having chronic kidney disease, FFA cannot be done.
FFA can be done, but provided you know, first of all, it depends on the degree of renal damage. Okay. That is why you're doing creatinine and all. Okay. See, if it is mildly affected or not, see, all the FFA cases, you have to get a fitness from the doctor and the cardiologist, okay, a physician. About let them decide the risk of it. Of course, you rightly said, the fluorescent dye is excreted from the kidney, and so it is important that the parameters are reasonably good. Depending on the values, you decide whether to do FFA. The benefit of FFA should be more than the risk involved. Okay. But in this case, it is quite obvious. So I don't think you need to do an FFA.
Sodium fluorescein dye is
percentage in the percentage area, there are two types of percentages available in the market.
okay,
10% under, 25% under. Okay, 10%, 25% under. If you're using 10%, you have to give around 5 ml. Okay. While if you're using 25%, you need to give only 2 ml of it. Okay. So there are two types. And then in the principle also you should know. See, see, it is quite obvious. You have clearly seen the NVE. You have clearly seen there is, you know, it is a definite, you can see the maculopathy, you can see the in one eye, the vitreous hemorrhage and also it's PDR is obvious and treatment also is obvious. But in some cases, when you get moderate NPDR and you get you want to know whether it is clinically significant macular edema, etc., you may have to do an FFA. The steps of FFA, you know the principle of FFA and the steps, the phases of FFA, all these things you have to know. An undergraduate student should at least have an idea, because even if it is not asked in your long case, there are FFA slides available in most hospitals. Your orals in the FFA slides may be shown, and they can ask the diagnosis, which of FFA, just read up. Okay. So FFA in this case, if at all you're doing, it's just to find out which are the areas of leakage where you may have to do focal laser. Focal laser whether it's in the macula or in the NVE areas, just to highlight it, you may have to do you may do an FFA. But if the renal parameters are bad, you may not do it. Okay, so depending on the renal parameters, you can decide about FFA. Okay. Any investigation you would like to do for this patient?
Investigations, sir.
Investigation.
Octa can be done.
Correct. It can be done. Octa can be done in this case, but it is not very important. Octa sadhana, choroidal lesions definitely you have to do it. But in Octa is not very important in this case because the management is quite obvious. But if your examiner keeps on asking for more investigations and you don't know anything else, you can definitely mention all these things. There's nothing wrong in doing Octa, but Octa illade you may be able to manage this case. It's not compulsory. Okay. So these are some of the investigations you usually do. Okay. And if you want to study you can use a 90D lens. You can do a gonio if you want to study the angle of the anterior chamber to rule out any NVE, any neovascularization of the angles, etc. Okay. If the intraocular pressure was slightly high, you may have to do all these things also. Angular no candy. Okay.
Okay.
So now coming to the treatment. Treatment right eye, you said you're going to observe and see.
In right eye, we have to observe whether vitreous hemorrhage is resolving or not. Frequent follow-up should be done. In the follow-up visits, if there is if the vitreous hemorrhage is resolving, we can do PRP in the seeing areas. And if the vitreous hemorrhage is not resolving, we can give anti-VEGF in right eye. And after that, if the vitreous hemorrhage is resolving, then we can do PRP in the right eye. In left eye, as there is NVE and the diagnosis and it is early confirmed case of early PDR, we can directly start pan-retinal photocoagulation in left eye.
Okay. See, in the past, we used to definitely wait. And we used to observe the patient for 1, 2, 3 months and see whether the vitreous hemorrhage is subsiding. And then if it subsides, then as you rightly said, you can consider PRP, etc. But of late, we try to, especially if this patient has not been subjected to any laser treatment before. Okay. So if the patient has not been subjected to PRP or laser treatment before, if you have got pre-retinal hemorrhages and you have got a dense vitreous hemorrhage and you do not know about the retinal status, we can consider doing an early PRP and vitrectomy also. Okay. In this case, because it is one eye, the picture is, he has not been subjected to PRP before. This vitreous hemorrhage will take some time to subside, and then later it may lead to tractional retinal detachment. It may be there also, a retinal detachment may be there already there. So it will be better that in this case, we in view of the fact that the patient has not been subjected to PRP or any photocoagulation before, and there's a dense vitreous hemorrhage, an early vitrectomy can be done. Of course, it is slightly controversial, but most doctors often now, because of our technology has advanced so much, and we can do vitrectomy plus PRP endolaser treatment together. Most surgeons now go for in the left eye. We may in the right eye, we may consider an early Paathsaala vitrectomy. Now, another thing which is slightly controversial or can be debated is whether to give pre-operative anti-VEGF injections. Okay. Now also people are now giving pre-operative anti-VEGF injections around 6 to 14 days before the surgery. There is a large study which did a meta-analysis of the available data, which has clearly mentioned that a pre-operative anti-VEGF injection given 6 to 14 days may be good in improving the results after vitrectomy and reducing the post-operative hemorrhage chances. So in this, in my view, right eye, it will be better that we give an anti-VEGF injection, and within 1 week to maximum 2 weeks, we go for a Paathsaala vitrectomy with fluid air exchange, endolaser, and silicone oil injection. Okay, that will be what is ideal. Now you should know about anti-VEGF. Which are the anti-VEGFs available in the market right now?
Ranibizumab, bevacizumab, and aflibercept.
Fine. And then you should know how it acts, how each one acts, the duration of action, all these things you can just read up. But then how does it act? It helps in causing vasoconstriction, and reducing the the vascular endothelial growth factor levels in the blood. So decreasing the chances of bleeding during the surgery part, and that is why you're giving anti-VEGF in this case. You should also know, see, sometimes the examiner may ask you what is the pathogenesis of diabetic retinopathy. That is the basic, actually, basic. Do you know what is the pathogenesis of?
Yes, sir. Yes, sir. Diabetic retinopathy is a microangiopathy. There will be microvascular occlusion at the level of retinal arterioles and capillaries and venules.
Okay.
And due to raised glucose level in blood, and excess glucose is converted into galactitol and sorbitol by the action of aldose reductase enzyme. And these sorbitol and galactitol will be accumulated in the pericytes and retinal cells. And these are osmotically active substances. So this will drag water into cell, and there will be inflammatory substances will be released. And due to accumulation, there will be loss of pericytes, and there will be thickening of basement membrane, and there will be endothelial cell loss. And also excess glucose will bind with proteins and form advanced glycation end product, and there will be free radical liberation and oxidative damage. And there is associated hematological changes like increased viscosity in blood and due to leukocytosis, and there will be Rolex formation in RBCs and increased platelet adhesiveness. And these all changes will cause microvascular occlusion, and there will be retinal hypoxia due to these changes. And these hypoxic retina will liberate vascular endothelial growth factor, and this will cause formation of new vessels over the disc and new vessels elsewhere, and neovascularization over the iris. And
Okay.
this will.
So the main thing is, one, there's loss of pericytes. Okay, pericytes, there's a basement membrane thickening. You get vascular capillary occlusion. You get areas of non-perfusion, areas of retinal leakage, and areas where there may be retinal edema. Okay, and then, as you said, there are growth factors released, inflammatory substances released, and one of the important growth factors is vascular endothelial growth factor, and you're giving anti-VEGF. Okay, and so prior to surgery, then you should also know the different types of diabetic retinopathy: non-proliferative, proliferative, and that itself is divided to mild, moderate, and severe. Yeah, and then with maculopathy or without maculopathy, and types of PDR also, as you said, high risk, all that, advanced, all that you can mention. Okay, now coming back to the treatment. See, you give anti-VEGF, you wait for 1 or 2 weeks, and then you don't wait for longer than 1 or 2 weeks, because these anti-VEGF can also lead to traction. Okay, and the fibrovascular bands which may be there may contract, and you may get tractional retinal detachment just because of the anti-VEGF which you give. So usually what we do is we just give the anti-VEGF, we decrease the chances of bleeding, and within 1 or 2 weeks we go straight into the surgical treatment. Okay, now you should know about pars plana vitrectomy also. In pars plana vitrectomy, what is the microscope type of contact? Is it a contact or a non-contact microscope that we usually use now to view the retina?
It is a non-contact.
Correct. It's a non-contact one, a biome. And with a biome, you get an inverted image, and there's an inverter by which you can see the things in which inverts the inverted images so that you can see better. Then you should know about the gauges which are used. What is the present gauge which we use for surgery? What gauge vitrectomy is usually used for? Vitrectomy probe is used. 23 and 25. Well, these are two ones which we use right now. Either 23 or
23 yes.
pardon? Under 19 and 20 but we don't use it now. We are using 23, 25 and 27 varying pone. 23 and 25 is what is usually used. Where are the ports made? Paathsaala vitrectomy, where are the openings made?
Three ports are made.
Okay, correct. That's
one
correct.
at-
3 ports. Correct.
One is at RIO clock.
3 o'clock usually don't put. 3 9 usually not put. You just put above and below. Okay, Mansar. But how many millimeters from the limbus do you enter?
4 millimeter
4 millimeter in which case?
in the intravitreal injection.
Intravitreal injection also you do like that, but 4 millimeters in which? See, there's a difference if it's aphakic and if it's fake.
Phakic and pseudo phakic.
Correct. So with 4 millimeters, air condition
In phakic.
yeah. See, if you have a normal lens inside, and if you go, you introduce, if you go at 4 millimeters, there's if you go at 3.5 millimeters, with a normal lens, you may sometimes injure it. So if it's phakic, you may you have to avoid you have to avoid injury to the lens, and that is why there's a difference between phakic and aphakic and pseudophakic. Okay, and the direction of your entry is always towards the center of the vitreous cavity, and your trocar should be directed central. One opening is for infusion, one opening is for the light source, and one opening is for a cutter. Okay, and so when you go in this case, you go first, you view the vitreous cavity, and then you start with doing a core vitrectomy, remove the vitreous hemorrhage which is there in the central part, and then you have to look for, when you go towards the periphery, you reduce the suction, the vacuum, and you go and you have to examine the retina to see if there's any retinal tear, retinal traction, and accordingly modify your treatment. Once you have removed the vitreous hemorrhage and you have seen the retina, if there is no retinal tear and tractions, then you have to put a fluid air exchange, and then in most cases we will put silicone oil also to fill the to replace the vitreous which you have replaced, which you have taken out. Okay, and you do an endo laser to you can do PRP using the endo laser probe, so that all the new blood vessels which have been NVI, if you see, can be regressed. Okay, so the treatment in this case for the right eye will be pre-operative anti-VEGF with Paathsaala vitrectomy, followed by fluid air exchange, silicone injection, and endo laser treatment. Okay, now coming to the left eye, what treatment are you going to give?
PRP can be given.
Okay. PRP can be considered, but there's a maculopathy also. So it has been mentioned that PRP can increase the maculopathy in this case. So you can give a focal laser, focal laser photocoagulation first, around just away from the macula, and then you give a PRP. Okay.
Okay.
Suppose you're giving a PRP, you should know about the different types of lasers you give.
Yes.
Green, red laser, all that, diode laser, all that you should know. The size of the laser spot, the duration, and the frequency, all that you can just read up. But then where do you start when you're doing a PRP? Where do you usually start with?
From
Which
the
quadrant?
inferior, start from the inferior quadrant.
Why?
To
Why?
avoid to avoid hemorrhage, bleeding, to avoid bleeding, and if there is more chance of bleeding, and it will settle down inferiorly, so we can do inferior PRP in later visit. So first we have to do inferior PRP, then
What you said is right. See, if suppose you are giving the laser to the upper part, and then some amount of bleeding occurs, the blood settles down to the lower part, and then it will be difficult for you to do a PRP in the inferior part later and the second sitting. So you usually give PRP to the lower part first, and then you in the second sitting you do the upper part, temporal part, etc. Okay, you complete it in the second sitting. So always remember to give it in the lower part, and then you go to the other areas. And usually the space between each laser burn also is important. You should give a laser burn which is grayish white in color initially, and you tighter the power depending on the pigmentation of the retina and the area which you are giving the laser. Okay, so now you are given a pan retinal, you have given a focal laser, and then PRP you are given. Anti-VEGF treatment may have to be given if you find that the macular edema is increasing or it is causing significant decrease in vision. You may have to consider an ERM peeling if you find that the macular edema is still persisting and vision is grossly affected. Okay, so in the future, anti-VEGF and ERM peeling may have to be done in this patient. You have to follow up the patients, because there's a chance that the patient's condition may worsen. So each patient has to be followed up around every 2, whether there is any new blood vessels being formed, and whether the condition is worsening or remaining stationary. Okay. Now, what are the other complications which may arise in the future in such cases?
In future, there can be tractional. There's a tractional RD can occur.
Correct. Tractional RDs can occur. Then, especially in the left eye, you can have a tractional RD, and you can then have to definitely go in for a Paathsaala vitrectomy and RD surgery. Okay, that's true. Anything else?
Neovascular glaucoma can be there.
That is, you have to already, there is neovascularization of the retina. So there's a good chance that in the future, the patient may develop neovascularization of the iris and angle. So always during your follow-up visits, I told you, you may have to follow up the patient every 2 months. So when the patient comes in addition to the fundus examination, just say with a slit lamp, look at the pupillary margin of the iris, and in doubtful cases, look at the angle also. Okay. And you will record the intraocular pressure. Yes. Any other complication which can occur in the future for this patient?
Mixed retinopathy can occur.
No, that's true. It is already, the patient may have mixed retinopathy. Yes. You can get in the right eye which we operated. You can get again vitreous hemorrhage. Okay. So you have done a vitrectomy and you have removed the vitreous hemorrhage. But post-operative period also, again, recurrent vitreous hemorrhages can occur. But what's the difference? What's the difference in the clinical course of recurrent vitreous hemorrhage following a vitrectomy surgery? See, before the blood which came was inside the dense vitreous substance. You know, vitreous contains collagen and hyaluronic substances, etc. It's a gel, okay? And so that is how you got the pre-retinal hemorrhages. Do you plan to do a ND-YAG laser hyaloidotomy for this patient before vitrectomy? See, ND-YAG laser can be used for making an opening in the hyaloid space and settling down the pre-retinal hemorrhage. That is usually done when you have a large pre-retinal hemorrhage right in front of the macula. Okay, ecasal macula is not, the hemorrhage is not seen right at the macula, and you can see diffuse vitreous hemorrhage along with the pre-retinal hemorrhage. So it is not in. That is why this ND-YAG laser hyaloidotomy was not mentioned in the treatment. It is not necessary in this case. But suppose you see a pre-retinal hemorrhage right in the front of the macula and our remaining periphery and all clear, then a laser can be done to try to settle down the pre-retinal hemorrhage. Now coming back, see, you in the Before vitrectomy, you have got a gel, and that is why this blood is suspended out there. But when you have done a vitrectomy and replaced it with air, later you see you have done silicone oil injection, then the chances of recurrent hemorrhage may not be there. But then in the future, you have to remove the silicone oil after 2 months or 6 months to prevent any increase in IOP, and for the long-term complications of silicone oil injection, you remove the silicone oil, and then you are replacing it with fluid, okay, ringer lactate solution. And so you may get recurrent vitreous hemorrhages in the future in this right eye. And there, when it occurs, you may have to consider vitreous lavage, okay, or you may consider removal of the hemorrhage and filling it with air, okay. So one complication which can occur in the right eye, which has been operated by vitrectomy, is recurrent hemorrhages. The second complication which can arise is a cataract formation, okay. So you can develop cataract following the vitrectomy surgery, okay. So that is why some surgeons simultaneously do a cataract surgery along with the vitrectomy surgery in these cases, okay. But then usually, theoretically, it is mentioned that cataract surgery plus vitrectomy surgery should be done if the cataract is quite dense and the view of the retina is interfered with. If you are not able to do a good vitrectomy due to the media opacity in the lens, then definitely you have to do both a cataract surgery and a vitrectomy together. But if your cataract changes are not very significant and you have a good view of the retina and you can do the vitrectomy without much problems, then you usually don't have to remove the cataract in the first sitting. You do a vitrectomy alone, but in the future, definitely this patient will develop cataract, okay. What are see in a patient, suppose it is you have a patient where there's a cataract and vitreous hemorrhage, and the cataract is a grade 4 cataract, or it's a mature cataract with vitreous hemorrhage. Then you have to do the cataract surgery first before you do a vitrectomy surgery. When you do a cataract surgery before a vitrectomy surgery for diabetic retinopathy, what are the small changes which you do in the cataract surgery steps? What are the things which you have to be careful, or which are the modifications you do in a cataract surgery if the cataract surgery is done before a vitrectomy surgery?
There is a chance of raise the intraocular pressure.
Okay. But that operation Mumbai, you bring it down, okay. Where ending capsulotomy difference undo? Capsule when you do a cataract surgery along with vitrectomy surgery, done to only okay, or cataract first followed by vitrectomy. Any difference in the usual steps? There are two differences. One, you have to do a large capsulotomy because later you don't want phimosis of the capsular bag, okay, or contraction of the capsular bag. So a large capsulotomy is done. You should try to do phacoemulsification surgery, because if you do SICS or make a large incision, you will have to suture the cataract surgery tunnel, etc., before you do a vitrectomy surgery, because you want a closed system when you do a vitrectomy. So a phacoemulsification surgery is what we prefer. 3, the lens which you put, you avoid silicone lenses. You don't put silicone intraocular lenses if you are planning to do a vitrectomy surgery, especially if the patient has got diabetic retinopathy. So because silicone lenses will interfere with the silicone which you may put later. And so the type of lens you put, the capsulotomy, and the type of surgery, these are all modified when you have to do a simultaneously cataract surgery and a vitrectomy surgery. Or in diabetic retinopathy patients, if you are planning to do a cataract surgery first, you have to keep this in mind, because the patient may have to have a vitrectomy in the future, okay. So these are some of the things about the future complications which the patient may have, okay. Retinal tears can occur You can get traction retinal mate canal also. You can get progression of the patient's PDR can advance, and you may have to do vitrectomy surgery, ERM peeling, etc. in the other eye also. Okay. Now, you in this topic, you may have to know about some other important clinical trials which are related to diabetic retinopathy. Can you just mention some few of them?
There is DRS study.
Yes.
DRS study. DRS study compared the effectiveness of argon versus xenon laser photocoagulation, and it studied about the effectiveness of PRP in proliferative diabetic retinopathy. And there is ETDRS study, which studied about the effectiveness of focal laser in the treatment of diabetic macular edema, and the role of aspirin in the aspirin to prevent the progression of diabetic retinopathy. And ETDRS study studied about the time of doing PRP. And
so what did it? Are in the findings, Aryama doctor? You are correct. What it looked into? What did it find? You told me three things: timing, then whether photocoagulation is important, useful, and aspirin. Findings or Aryama?
Aspirin has no role in the in preventing progression of diabetic retinopathy, but it will prevent the progression of other microvascular complications.
Correct.
And focal laser is effective in the management of diabetic macular edema.
Okay.
And PRP should be done in case of early PDR and high-risk PDR.
It found it was able to say that photocoagulation helps reduce the visual loss in macular edema.
Edema.
Then studies on doctor?
Diabetic DRVS study, diabetic retinopathy vitrectomy study.
Correct. Very good.
It compared the early vitrectomy versus conventional vitrectomy. And
they found that early vitrectomy is useful for non-clearing vitreous hemorrhage. Then in type 1 diabetes, then one-eyed persons, okay, one-eyed persons. Those who have not been subjected to lasers before, okay, no treatment. Like e patient 1 week, sudden decrease in vision and no treatment, no patient didn't have and we are not able to do a PRP for this patient because of the view is quite markedly reduced. Okay, so the diabetic retinopathy vitrectomy study was able to give all these findings. Okay, where any studies on top?
DRCR.net trial, diabetic retinopathy clinical trial.
Correct.
It includes several protocols. Protocol is compared the effectiveness of intravitreal ranibizumab with laser PRP, and the conclusion was intravitreal ranibizumab is superior to pan-retinal photocoagulation in the management of diabetic macular edema. And protocol T compared the intravitreal anti-VEGF aflibercept, ranibizumab, and brolucizumab. And in case of mild to moderate, mild NPDR, there is no benefit in aflibercept is always superior. In case of moderate to moderate NPDR and NPDR, in case of mild NPDR, all the intravitreal injections are have same effect, but aflibercept is having higher cost, and if there is bevacizumab has side effect, but it is less costly.
That is okay. In the findings, that's a fact. See, actually, ranibizumab plus retinal laser photocoagulation was found to have a better visual results than only laser. Okay, in diabetic retinopathy. Then they also studied whether subtenance triamcinolone can be given in DME. and it was found to have not much of benefit as an adjunct to micro laser photography. Okay, these are some of the different trials which they did. Okay, പിന്നെ വേറെ എന്തെങ്കിലും older studies ഉണ്ടോ?
There is UKPDS study.
That also
UKPDS study, control of diabetes and hypertension will reduce the microvascular complications of diabetes. And there is a DCCT trial, diabetes control. DCCT trial studied the effectiveness of the control of diabetes with insulin will reduce the progression of diabetic retinopathy.
Diabetic control and complication trial was the one which helped us to understand that in type 1 diabetes, strict glycemic control is useful in avoiding reducing the complications. While in the UK prospective diabetic study, it was found that strict hypertension control, BP control, is useful in reducing the progression in type 2 diabetes. Okay, so in your exam, in addition to the treatment which we just now mentioned, we talked about laser treatment, we talked about surgery, etc. Please realize that you have to also mention lifestyle modification. That is also important. Lifestyle modification, decrease in weight, exercise, better blood sugar control, better lipid control, especially in e-patient lipid dyslipidemia under, you have got so strict control of lipid levels, the strict control of blood sugar levels, strict control of hypertension. All these also should be mentioned along with your treatment details. And that is all based on this diabetic control and complication trial, UK prospective diabetes study, and all those older studies helped us to get all these data. Okay, so at least a few trials you should know. And not only in diabetic retinopathy, suppose you get retinal, you get CNVM, or suppose you get central retinal vein occlusion. If any of these retinal conditions you get in your exam, there are trials which are associated with it. You should be able to, in the exam, mention about a few trials because the examiner may ask that. Okay, then what else? Just do you know what is the word meaning of retina? Since the topic is retina, I don't know. What's the word meaning of retina? How did that word come? Any idea? What is retina? Actually, at a retina, it comes from the Latin word R-E-T-E, which stands for net. Okay, net-like structure.
Okay,
they taught that retina is a net which holds the lens and the vitreous inside. Okay, so it, it's a third coat of the eye, and then inside you have got a vitreous and you have got in front the red lens. But they assume that it is like a net which holds it together, and so from the Latin word R-E-T-E, the word retina came. Then do you know when the first person saw a diabetic retinopathy change? Like diabetic retinopathy, I don't know. These are historical things just for your general knowledge. Like see, who was the first person who saw all these diabetic macular changes, diacasyl maculopathy on the, and so who first described it? When did they first describe it? Any idea? To see the retina, what is the instrument we usually use?
We usually use ophthalmoscopy.
Ophthalmoscope. That is direct or indirect?
Direct ophthalmoscopy.
Direct or direct? When was it first found? When was the first direct ophthalmoscope used in the world? Roughly. എത്ര വർഷം മുമ്പേ ആണ് ഇതെല്ലാം കണ്ടുപിടിച്ചത്? It is in 1855, 1850s, 1850s. So just imagine, it is more than 170 years back. 170 back in 1855 is when the first direct ophthalmoscope was described. And the very next year, in 1856, a man called Edward Jagger. Edward Jagger is the one who first described diabetic maculopathy changes. Okay. And this Jagger is important not only in maculopathy. He was the first person who described it in his thesis. He first described. Jagger is also important for something else. Where every I term caretaken? Jagger.
Jaggers. Visual acuity chart.
Very correct, very correct. He is the one also, visual acuity chart around Jagger. So he has made charts and he used a ophthalmoscope, direct ophthalmoscope to describe diabetic maculopathy changes. Okay, fine. So these are some just historical things which you should know. So in short, see, you should be aware about what is the basic pathology of diabetic retinopathy. You should know the investigations which are done in it. You should know that the medical treatment, namely the use of anti-VEGF, etc. You should know about the pan-retinal photography, the lenses used, the machines used, the types of laser used, all that you should know. Complications of doing retinal photocoagulation. You should know about the steps of surgery also. You should know the procedure and also the complications which can occur. Okay, and sometimes you may have to know also the vitreous substitutes which are used after a vitrectomy surgery. So this is in short the things which you should know in this topic. Any doubts you have, you can ask. Where any topic discuss cheyanengil. Theoretically, it is the investigation which gives the earliest indication of whether a patient's eye may develop diabetic retinopathy or not. Which investigation is said to give you the earliest indication about the chances of developing diabetic retinopathy.
FPSP blood.
The FBS-PPFS you cannot predict whether a patient will develop diabetic retinopathy or not.
HbA1c. HbA1c.
HbA1c is important, but then that also gives you an idea about the complications. They had studied that diabetic control and complications trial, and they had studied all it. But then there's a study called Wisconsin's epidemiological study of diabetic retinopathy. HbA1c, BP, DRL, okay. But then if they ask which investigation, we give the normal retina, a normal looking retina. If you want to really know whether this retina will develop diabetic retinopathy in the future, the investigation which they mention is what's called ERG. Okay, ERG. If you see that the amplitude of the B wave is less, or the implicit time for the first oscillatory potential is also less, then there's a chance that this retina will develop diabetic retinopathy in the future. But then it is practically not possible for us to do ERG in all our patients. So that is why we are not using that instrument as a screening method to screen for patients. But you should know what is the screening protocol which you should advise your patients to come for a regular checkup. See, if a patient is type 1 diabetic patient, type 1 diabetic patient comes to you, when is he supposed to screen for diabetic retinopathy?
After five years, we can
that is what
do screening. That
is right. Anuja correct. They say that a type 1 diabetic patient, when diagnosed first, you have to within 5 years. For 5 years, it will take for the diabetic retinopathy to occur. That is, if puberty kainite or middle age or 5 years kainite, usually the patient will develop. No, there's a chance. So screening for type 1 diabetic, newly detected type 1 diabetes is after 5 years. Now the next question. Screening for a newly detected type 2 diabetes. When is it supposed to?
As early as possible.
Correct. At the time of diagnosis itself, you have to tell them to be subjected to a dilated fundus examination. And then suppose there is no diabetic retinopathy, how frequent will they be followed up?
Annual fundus examination should be done.
Yearly. Then when does the frequency come down?
If there is mild NPDR, we can do follow-up visit 6 to 12 months.
Correct.
And if there is moderate NPDR, 6 monthly follow-up can be done.
Okay.
If there is severe NPDR, 4 months, 4
Okay.
monthly follow visit should be done. And if
2
if
to
it is
4 months. 2 to 4 months.
4 months,
Especially with maculopathy. Maculopathy patients, you have to follow up at least every 2 months. Okay. PDR cases.
if there is very severe NPDR, 3 monthly follow-up should be done. And early PDR, 2 monthly follow-up. And high risk PDR, frequent follow-up should be done.
Okay, so that's it. So ERG and all no one is doing here. It's mainly experimental and ones, but then you have to understand the importance of regular follow-up for these patients and seeing if any complications are developing during the follow-up visits or any change in the pattern of the retinal blood vessels in each visit. Okay, were any doubts on the? Do you want anything else to be discussed or can we stop? Elizabeth on the?
Sir, right eye vitrectomy.
Yes,
Sir,
Right
right
eye.
vitrectomy ചെയ്യുന്നതിന് മുന്നേ എത്ര നാൾ വെയിറ്റ് ചെയ്യണം സർ റൈറ്റ് ഈ കേസിൽ ഉടനെ early vitrectomy can be done now?
In my view, right eye already there's a witness to this patient. Mumbai laser only cheyidilla. Answer. And that's why occupation also is important. See, laser only cheyidilla. He was not even aware about his condition. And now he has come with sudden decrease in vision. We are not able to see the the retina, etc. Onningal, there are two schools of thought. Onningal normal B scan elan cheyidittu, we confirm that there is no fractional retinal detachment. The retina is normal, okay, and there is only a vitreous hemorrhage which is not very dense, okay, and then we can observe right eye the vitreous hemorrhage you may observe for 1 month, okay, and then see whether the vitreous hemorrhage is subsiding and whether you get a view of the retina for doing pan-retinal photocoagulation, okay. But then suppose now with better results with vitrectomy and the fact that you can do endo laser photocoagulation along with the vitrectomy, and there may be an underlying retinal detachment or a retinal tear. They state that it will be better that you do an early vitrectomy for this patient. So the patient, depending on his, you discuss the treatment options with the patient. If he is willing, I will go for anti-VEGF injection whenever he can afford, as early within 1 or 2 weeks. Then wait for 1 week, and after within 1 week after the anti-VEGF is given, I will do a vitrectomy followed with endo laser treatment and silicone oil injection. Okay. So how early in total? Because the eye has not been lasered before, because the patient was not even aware of it. See, you have to understand that already other eye also has got PDR changes. So the PDR changes under, you don't want him to lose 3/60 height under, and B scan namal cheyidilla, so I don't know whether there is any retinal detachment and all. So I would prefer an early vitrectomy for this patient, and during the vitrectomy itself, do an endo laser photocoagulation. Yeah, photocoagulation the principle photocoagulation, what is done is you are giving light energy which will be converted to thermal energy which coagulates the proteins, and this coagulation will help convert the retina into anoxic retina, decreasing the production of this vascular endothelial growth factor and all these inflammatory substances. It reduces the oxygen demand, helps to prevent proliferation of the retina. That's why you're doing all this photocoagulation. Okay, so yeah, I would prefer doing an early vitrectomy in that right eye, which is the one which is affected, and doing simultaneously an endo laser and silicone oil injection for that eye. And sorry, but then suppose the patient has, say, your fitness only or patient doesn't want surgery, then you can always wait for 1 month. You wait for 1 month, see whether the patient, and then after the B scan becomes important. You document the vitreous hemorrhage, you document the retina, and then 1 month community, you take a repeat B scan, see how the retina is, see how the vitreous hemorrhage, and you do a fundus examination to see whether the view is better or not. And if the view is completely better and no retinal detachment, and then PRP, no need of surgery. PRP chedamati, PRP and winning anti-VEGF anti-VEGF done if you think there is recurrent hemorrhages. But then if you think there is no change, then definitely within 1 month I would do a vitrectomy. And your doubt is clear, really?
Yes, sir. Yes, sir. Yes, sir.
Where any doubts ആർക്കെങ്കിലും ഉണ്ടെങ്കിൽ ചോദിച്ചോളൂ. അല്ലെങ്കിൽ it's already 1 hour or 1.5 hours. If you want, you can stop. Elizabeth,
Okay,
should we
sir.
continue or-
Okay, it's if we can stop, we can stop, sir.
അല്ല വേറെ ആർക്കും ഡൗട്ട്സോ എന്തെങ്കിലും ക്ലാരിഫിക്കേഷനോ എന്തെങ്കിലും അഡീഷണൽ സംസാരിക്കണമെങ്കിൽ സംസാരിക്കാം, അല്ലെങ്കിൽ വിൽ സ്റ്റോപ്പ് റൈറ്റ് നൗ. ഓക്കെ. Okay, Anuja, thank you for taking the initiative to present this case, and
Thank you so much.
Dr. Elizabeth also. Thank you for organizing and coordinating the whole thing. My best
Welcome,
wishes
sir.
for the
Thank
PG
you so
students
much.
for their future academic and professional life. Okay.
Thank you, sir.
Thank you, sir.
Thank
Thank
you,
you,
sir.
sir. Thank you, Anuja.
Thank you, madam. Thank you so
Okay.
much, sir.
Good night, sir.
Thank you, sir.